Greetings. We're going to be talking about seizure pharmacology. Okay, so here are the learning outcomes for this module. Okay, so when we're thinking about why we use medications to control seizures, again, we're trying to control that abnormal neuronal activity of excitatory firing, right, that causes the seizure. This module is going to look through the three different mechanisms listed here. There is this new one that is coming out, though, with looking at directly innervating glutamate that we're going to speak of in 232.02 next winter. So here are some key terms to keep in mind when we're looking to the literature, looking to our resources regarding some use of these medications, because you'll see them come up quite a bit. You'll also see a lot of these medications that kind of do dual duty with not only seizures, to control seizures, but also use in psychiatric diagnoses and when a need for an anxiolytic is also needed for a clinical state. So just be familiar with them. So I spent some time really looking for a good royalty-free picture to kind of communicate how does this all work at the patho level. Couldn't really find one that really was succinct and to the point, so I borrowed this from YouTube. So when we're thinking about how our neurons communicate with one another, you have the presynaptic, right, the cleft, and then the postsynaptic. So let's start with the basics. So you have that neurons that communicate with each other through various neurotransmitters. So when one neuron is stimulated, the release of an excitatory neurotransmitter, such as glutamate, will be brought over the cleft so it can bind to the receptors on the next neuron. So with this, it causes the next neuron to depolarize and release its own neuroexcitatory transmitters, okay? So this propagates the signal throughout the brain to cause an excitatory state. So the action potential begins with the opening of these sodium channels, these voltage-gated sodium channels to be more specific. And with this, sodium moves into the cell. Okay, once sodium moves into the cell, again, and sodium is going to be an excitatory cation here, it's going to open the high voltage calcium channels, right, to allow calcium into the neuron as well. And this combination of sodium influx and calcium influx causes glutamate to be released from the vesicles and move into synaptic cleft. And you can see in this demonstration, it's signified by these green dots, okay? So once glutamate is present in the synaptic cleft, it binds by two different types of receptors that you see here, okay? We have the AMPA receptors on the left, and we also have the NMDA receptors on the right in this depiction. So the AMPA receptors allow for sodium to enter into the postsynaptic neuron. The NMDA channels open and they receive calcium, okay? So with this, you have the movement of the excitatory impulses from the presynaptic cleft through the postsynaptic cleft. So this all works great. And in the body, we also have, again, I'm going to put up my proverbial scales with my hands of that yin-yang concept in maintaining homeostasis. Because if all we had was this excitatory neurons moving throughout our clefts all the time, we would all be seizing constantly, right? So this is where we have the application of chloride and GABA to kind of keep everything in check in the non-epileptic state. So let's pause and just kind of take another minute to think about that. So all these positive ion influx, sodium and calcium, right, cause depolarization of the cell. And this increases the neuronal impulse. So we need that inhibition of chloride that is brought in via the release of the GABA, you see from this side neuronal area, so that we have the excitatory that comes in and crosses over to allow for the impulse to occur, but keeping it in check with GABA and chloride ions at the postsynaptic. So this inhibitory component, which encompasses GABA, right? It's a balancing component, really, if you think about it, to keep the over-secretion of glutamate in check, so we don't have this overabundance of excitatory impulses coming down the cleft. GABA allows for the negative chloride ions to come into that postsynaptic cleft. They kind of bind up, right, and neutralize some of the excitatory of the sodium and the calcium. Again, we're back to chemistry here. So in the person with epilepsy, though, and other type of seizure disorders, they have this overabundance of excitatory neuronal activity, right? And the inability to have enough GABA to balance the increased glutamate release and neuronal, again, keep that neuronal hyperexcitability in check. So this is the concept of a lot of the mechanisms of actions that we're going to speak of in this module. So I've separated the different medications that are commonly used to treat epilepsy by their mechanisms of action. So first we're going to talk about the drugs that potentiate the GABA action. And as the name implies, by changing the action of GABA, which stands for gamma aminobutyric acid, but GABA is fine for this course, that is the primary inhibitory neurotransmitter in the brain. And it's a predominant effect of when we have potentiation of GABA, that's going to be CNS depression. Okay, so let's talk about benzodiazepines, as they have clinical application for seizure activity, but also for many, many other disorders and clinical application as well. So one of the most common ones we utilize are these benzodiazepines, which we often will refer to as benzos. Sometimes we refer to them by their acronym of BZDs. Regardless of how we call them, again, their mechanism here is the inhibitory neuron secretes GABA, as we talked about before, right? And GABA allows for negative chloride ions to enter this postsynaptic cleft. It's going to help decrease that neuronal excitability, right, of the cations of calcium and sodium that are coming from the presynaptic cleft. So with benzos or benzodiazepines, their mechanism is to increase GABA activity by binding to these GABA A receptors and therefore stimulation of the GABA channel opening, right? So this allows for more binding, the binding of more GABA and the influx of more chloride ions into the postsynaptic cleft, right? And with all these receptors occupied, it means that no further excitatory impulse can bind, right? So it's going to decrease that excitability as they move across that membrane. So again, let's look at the more commonly used ones of the benzos. And again, you see these all end in PAM to help with memorization. So again, the mechanism, as I said before, we're going to increase the frequency of the chloride channel opening, right, at the postsynaptic neuron, and that's going to lead for increased efficacy of GABA, right, and efficiency of GABA to decrease neuronal cell excitability and communication with the neuron. We say it a different way. The benzodiazepines bind to the GABA receptor chloride channels throughout the central nervous systems and produce the effects by suppressing the neuronal activity within the limbic system. So with this, obviously will come sedation, right? Also will often be referred to as anxiolytic, decreased anxiety, right? You may have some individuals that have a muscle relaxation. It also has, when given IV, an anticonvulsant activity, especially for a person presenting with status epilepticus, where you have a continual seizure lasting more than 5 minutes. And this can obviously be a very life-threatening potential. Now, given that some of these adverse effects, especially when utilized in the IV approach, you have to worry about the muscle weakness, which can lead to respiratory depression. So if we're going to be giving this for seizures, we're going to need to have airway and resuscitative equipment readily available at bedside. if we're using this for the PO version, as some people do, there is a high level of tolerance and dependency that's associated with the benzodiazepines. And so this is where we need to do a lot of patient counseling. As you move into the provider role, this is an area you're really going to want to stay away from unless you absolutely have to utilize the benzodiazepines. You may even see diazepam, brand name more known as Valium, that is also utilized in the OB/GYN setting as a treatment for eclampsia, again, as we know, which is a life-threatening complication associated with pregnancy in some pregnancies that can be resulting in the individual having seizure activity. So I want just to include nursing considerations regarding benzodiazepine withdrawal, because this is something you will see in the clinical setting at times. So benzos have people can misuse them because, again, they do have an anxiolytic effect. They have a slight euphoric effect in keeping them calm. So this can lead to sometimes use and abuse, right, due to these effects. Even when used at therapeutic doses for, a non-abuse type of setting disorder, they can cause that physical dependence. And if a person should do a sudden withdrawal or sudden decrease, sudden abrupt stopping of the medications, they can lead this into a benzodiazepine withdrawal. This was especially prevalent if I'm going back a decade or so. With the period between the late 90s and the mid 2010s saw an ever increasing amount of individuals on benzodiazepine prescriptions for various things. And what we were seeing as nurses in the hospital setting, that we're seeing a lot more people coming in with these benzodiazepine withdrawals because they would stop taking them suddenly. And it can be very life-threatening, as you can see from this, and that's what would land them in the acute care setting. As future providers, I really encourage you all not to utilize the benzodiazepines unless absolutely necessary, because we're just coming out of that fog of that time period not that long ago, where we were really, really overusing them. If you do see a person in a benzodiazepine withdrawal, they generally will peak on this. The symptoms of this will peak on the second day post sudden stoppage of the medications, and usually they see a remarkable improvement by the 5th day. But again, these withdrawal symptoms can be so intense that they may need hospitalization. What to do if a person does need to go off of their benzodiazepines? We really need to do what's called a taper, which means taking progressively smaller doses over a course of a few weeks of the medication to kind of slowly rid the body of this impulse and minimize the chances for this withdrawal symptoms. Now let's look at a class of drugs that are under the barbiturate category. Again, the most common one you're going to see is phenobarbital, which is helpful to remember. It's a barbiturate because it's in its name, right? So they act fairly similar to the benzodiazepines, but here's the big difference. They hold that GABA ion channel open longer. So again, increased duration to allow for more chloride ions to filter in, right? And that's where we have that ability for the barbiturates to actually help control the seizure activity, right? That increased neuronal hyperexcitability. So with this holding the door open, and I put these little cartoon guys here, they allow those channels to open up, right? Even when GABA maybe not even be present in the cleft. So again, allowing for holding the door open, increase in the duration allows for more chloride to come in, even if GABA has been used up by the body. And this is going to produce that inhibitory effect that we spoke of. So like their benzodiazepine, we'll call them cousins here, they do have the potential for dependence. So that's something we need to be aware of in the patient population. They also Unlike benzodiazepine, they even have a lower therapeutic index. So we know by history with this course, that means increased potential for adverse effects, increased need for monitoring during the duration of the therapy, and also increase for more drug-drug interactions. So again, they act biochemically by enhancing the action of the GABA neurotransmitter by keeping them open longer to allow for chloride ions to come through. We have utilized this for decades in seizure control. There is some off-label use of it that is not highly encouraged at all in promotion of sleep. Again, because of all the things that we have talked about. So people should not be utilizing it for insomnia. It should be used primarily for seizures. It's on that schedule, and I know I haven't spoken of the schedules yet, but we will in the next lecture. It's a Schedule 4 drug, so the potential for dependence is present. Obviously, you're going to have drowsiness that can occur due to this mechanism of action, but overwhelming drowsiness could be a consideration of an adverse effect associated with this. So I just wanted to include a patho slide here, and how does this all work all together that we've talked about, kind of summative slide here. So when we have the increased effect of GABA, we have the increase of chloride ions, and that leads to decrease in neuronal excitability, right? Keeping the GABA-induced opening of the channels open for longer durations is going to lead to an increase in the ionic flow across the membrane and produces that inhibitory effect, which is the mechanism of action of the barbiturates. So the medications we just talked about, the previous two slides, target the benzodiazepine site of the GABA receptors, which are located, as you see on these alpha-1 and beta-1 subunits of the receptor. No need to memorize that. Just trying to illustrate how all this is working and give you kind of an idea in your head, at least with a picture, of how this actually interacts with these neurons. Okay, so now let's look at drugs that suppress the sodium influx. So let's start off this part of the lecture talking about a very common one you'll see in use is the valproic acid, which is also better known as valproate or Depakote. So the mechanism of action with the valproic acid and its derivatives, they're very widespread. So with this, you have this enhancing of GABA, so again, inhibitory, right, GABA, calming GABA, at that postsynaptic receptor site. Its main focus, though, is that desensitization of the sodium, the high voltage sodium channels that cause that influx of sodium ions that lead to neuronal cell hyperexcitability. So this is a very good medications to utilize with seizure disorders, all types from absence all the way up to the grand mals. You will see some dual usage with the psychiatric diagnoses as well, and also it's actually been found very effective as prophylactic for migraines. Again, for another lecture, but we will speak of that soon. So we can utilize this medication for people with a variety of issues regarding increased neuronal cell hyperexcitability. So it is thought to have a similar effect to another class of medications called the phenytonin medications, which we will talk about soon, brand name of Dilantin there. But just kind of putting this all in perspective, sodium is excitatory in nature, right? So decreasing or inhibiting sodium channels, the high voltage sodium channels, will cause a decrease in excitatory activity. Hence, you're going to really decrease that potential of that hyperexcitability to cause a seizure in individuals who have epilepsy or epileptic-like conditions. For our pediatrics, this is one of the medications we can open the capsules and sprinkle onto a soft food, yogurt, ice cream. Of course, they have to eat and consume the entire amount to get their dose, but it's a very easy way in getting children who have epilepsy to be able to tolerate the medication. This is a known teratogenic substance. It is known to cause spinal bifida, which is a neural tube defect. So we're going to not be utilizing this in persons of reproductive potential that are going to be trying to be pregnant while on use of this. Okay, another class we're going to talk about are the hydantoins. Most common ones are phenytoin and fosphenytoin. Phenytoin is going to be referred to very often in clinical settings as Dilantin, its brand name. Again, this mechanism of action of these drugs include the sodium influx suppression, right? So with this, you're going to have a desensitization to the sodium channels within that presynaptic neuronal axon, and then it's going to, by having the desensitization, it's going to prevent the spread of the disruptive electrical charges in the brain that are present in individuals that can produce seizures. So it's very effective against many, many different types of seizures, with the exception of the absence seizures. I have another drug that works well for that we'll discuss momentarily. It also has a bit of an antidysrhythmic activity. So this is where we need to have monitoring of cardiac dysrhythmias, EKG, especially with the start or initiation of this class of medications. So when I was learning this, 20 years ago, there was a big concern regarding persons of pregnancy potential. And there still is with use of this medication. However, there's been numerous studies, and I actually found a really good one just from last year that kind of documents each of the different type of medications that we've been talking about today and their effects on potentially of a developing fetus. So we will talk about that we need to have a discussion with patients if they are of pregnancy age potential for utilizing proper birth control, usually 2 forms of barrier birth controls with use of this medication. In the past, it's thought to be a high incidence of causing, not high incidence, but higher than normal incidence of craniofacial malformations and also limb deformities. Now again, as I've looked through more recent literature, there is some debate on this. So we will leave it as a not for use in pregnancy, but consult the literature as to the latest and greatest of the evidence that is known to date. And I've included the citation here at the bottom, and also I will include it on your CLE, the whole article. And this is important for those of you that will be going into OBGYN, but also in those in family practice, those who are going to be practicing in the acute care settings, because as we know, pregnant patients are not just siloed into just going into their OB or GYN provider. There's a multitude of providers that will be seeing them. Okay, another drug that limits the influx of sodium ions into that presynaptic cleft is carbamazepine. Again, a lot known by its brand name of Tegretol. So with this, again, carbamazepine is known to increase the sodium channel's refractory period, right? So with use of this, you're going to have the time that the receptor is bound and not active, and thus it's going to have an inhibitory effect on sodium coming into the presynaptic neuron. It is utilized a lot for partial seizures. As you can see, there is also effect within the psychiatric diagnoses of bipolar disorder. What I see it most used for, and what I have used it most for, is something called trigeminal neuralgia. So I'm going to take a second. I want you to put your fingers on your face. Your hand should be just above your ear, just like this. So your second and third fingers help you remember where the trigeminal nerve has its application. And trigeminal neuralgia is, in brief, is a very debilitating disorder that stems from this trigeminal nerve distribution, which causes this intense pain, very intense pain, that really doesn't respond to opioids very well. It really does respond, though, to carbamazepine. So very, very beneficial for that. There are some considerations, though, that we need to be wary of with use of this medication. Again, there is a known higher incidence with carbamazepine of something called Stevens-Johnson syndrome, which I have a picture of in the next few slides to discuss more about that. There's also, it's not for use in individuals that could be pregnant, right? It does also have a higher incidence of dizziness and lethargy, so elderly patients tend to not do well with this medication as well. So now we're going to look for drugs that suppress the calcium influx. Okay, moving on to a drug called ethosuximide. So this is a member of the suxamide classification, and how I remember that, it has sux, S-U-X, which is similar enough to suxamide, so I can remember that classification. This is the preferred drug for treatment of absence seizures. So I want to call attention to the change in mechanism of action here from the other agents that we discussed previously. So with this, you have that depression of the nerve transmission by suppressing the calcium influx into that presynaptic neuronal cell. Still has some of the same characteristics, though, of the sodium suppression drugs that we have spoken of already, including drowsiness. This one in particular, you need to monitor their CBC a little bit more intently due to the potential for something called agranulocytosis, so a decrease in all of the immune system components, which can lead them open to, of course, infection potential. This one has been noted for, and some patient education is needed regarding if their mood changes drastically and that they need to contact the office. Like the other counterparts that we've talked about in this lecture, this one is not for use in pregnancy. There's also some contraindications for those with severe liver and kidney impairments. Okay, let's spend a moment and talk about Stevens-Johnson syndrome. So SJS is a rash that can develop with numerous medications. It has a higher incidence in a lot of the anti-seizure medications that we're speaking of, so this is why it's included here. But it's not limited to seizure medications. So this is why we have that nursing considerations of really paramount in educating the patient to report any new finding of a rash to the provider so that we can evaluate it, because it needs to be treated fairly quickly once it's considered and once it's seen. We need to stop whatever the causing agent is, okay? And often persons will need to be coming into the hospital if they're having one of the more severe reactions that, like you see here. And I tried to include a variety of skin tones so you can kind of get an idea of how this presentation of this Stevens-Johnson syndrome rash looks. The concern with this rash is that it can lead from the rash part to something called toxic epidermal necrolysis or exfoliative dermatitis, as you see here. I want you to call your attention to the one with the days here. You can see this patient in their presentation and with treatment, how it improves over a course of about 10 to 14 days. Again, identification is key, and stopping of the drug and then treatment for this. So one classification of medications that block both the calcium and the sodium channels. So lamotrigine, or as it commonly is referred to, its brand name of Lamictal, is another anti-seizure, anticonvulsant classification of medications that were initially used with seizure activity. They've also found that it's very, very effective in treating bipolar disorder as well. So you can see the mechanism of action here. This is where it's going to inhibit that glutamate by kind of both preventing the influx of sodium and calcium into that presynaptic membrane. If you have a limit of that, then again, you do not have much of release of the glutamate that transfers over that synapse and can start this aberrant type of firing that's associated with seizures. Again, fairly well tolerated. Lack of appetite is a big one with this medication, so we need to make sure we are instructing the patient on that and advising them they may lose some weight. They may need to maybe eat a bit more to gain weight if they're on the lower BMI scale of that. We also have found in younger people utilizing this medication that there is an increase in suicidal ideation. So we need a lot of education about discussing worsening of mental health with use of this. It's not something that we can stop taking abruptly, as you've seen in all these other medications that we've talked about. There's also documented cases of that Stevens-Johnson syndrome, that rash, especially in the younger patient population that utilizes this. Okay, so as we move to conclude this lecture, I did want to talk about one of the agents we have should you have an individual that has an overdose of benzodiazepines, and this is going to be the flumazenil. Again, most often known as romazicon, but it is flunazenil. So again, this is an antagonist for the benzodiazepine receptors that you will see utilized in the acute care setting quite a bit. So again, it is dosed per weight base, and you can see the usual dose is 0.2 milligrams given IVs only. I want to make sure that you understand that this is specifically for the benzodiazepines and not for their cousins of the barbiturate overdose as well. But this is something you will see if a person is on benzodiazepines for whatever reason. This will also be in their PRN section of their medication administration record, just in case. So patient teaching is a key component and also centers around minimizing any of the adverse effects of the medications that we've been talking about. Again, since many of them are contraindicated in pregnancy, that is a discussion that needs to be had. Sometimes providers will recommend 2 forms of birth control before prescribing these to someone who could become pregnant. Want to know if there's any unusual drowsiness that can occur, because that can be shown as an overwhelming response to the medications, and the person may not be able to, have their normal course of daily life with use of that. Alcohol, certain over-the-counter type of medications, and even the herbal medications can counteract and either inhibit the effects of the medication that we're giving, or maybe make it much more worse. St. John's wort comes to mind in terms of the herbal preparations, so we need to make sure we're educating on that. And a lot of these, again, as I said, are really hard on the stomach, so taking with food is yet another thing. Okay, let's take a moment and do a test your knowledge. Which of the following medications treat seizures by limiting the sodium ion influx only into the neuron? So again, calling into some recall of the mechanisms of actions. It would be lorazepam, phenobarbital, ethosuxamides, or the phentonates. Okay, so the answer is going to be D here. This is the phenytonin, or those are the ones with specifically suppression of sodium influx. Here's a summative table to help with your studying for the exams regarding the different classifications of medications that we've talked about. As always, I welcome any questions you may have. Thank you so much for listening.